Considerations in metastatic castration-resistant prostate cancer. Prostate cancer is the most commonly diagnosed cancer among men and is the second leading cause of cancer death among men in the United States. Prostate cancer is largely curable when diagnosed and treated early. However, locally advanced and metastatic disease treated with hormonal therapy typically leads to remission lasting 2 to 3 years. 30% of men with metastatic prostate cancer are alive at 5 years after diagnosis. It is well documented that prostate cancer is an androgen-sensitive disease. For this reason, standard treatment for advanced prostate cancer includes androgen deprivation therapy, which lowers serum testosterone levels. However, tumor growth eventually resumes after androgen deprivation therapy, despite achievement of castrate serum testosterone levels. The disease has historically been referred to as androgen-independent or hormone-refractory prostate cancer. These terms may not accurately describe the disease state. Androgens remain the primary mediator of prostate tumor growth and progression. A more medically accurate term to describe this phase of the disease is castration-resistant prostate cancer, CRPC. Recent basic science and clinical evidence suggests that one possible cause of metastatic CRPC, mCRPC, tumor progression is that the tumor becomes hyper or supersensitive to low levels of androgens in the microenvironment. The androgen receptors can become activated even though the circulating testosterone has been decreased to castrate levels. Additionally, in both animal and human studies, it has been demonstrated that tumor cells produce androgen to help sustain their own growth. Normally, testosterone and other androgens are produced in the testes and adrenal glands. A chain of enzymatic reactions converts cholesterol into several different intermediate structures, ultimately producing testosterone and other male hormones and androgens. In mCRPC, it is believed that the tumor itself is capable of synthesizing its own source of androgen growth factors, while levels of serum testosterone remain low. This, in combination with a hypersensitivity of the androgen receptor to this alternative source of androgen growth factors, could result in self-activation of the tumor. In other words, in mCRPC, there is evidence to suggest that the tumor may be providing its own growth factor in the form of androgens to bypass its dependency on testosterone alone. While other pathways can also contribute to prostate cancer disease progression, these recent findings support the position that mCRPC is still sensitive to androgens, often with synthesis of these androgens coming from the tumor itself.